Okay, well, good afternoon, everyone. My name is Bob Emery. Welcome to another edition of the TEPHI Talks, the Texas Epidemic Public Health Institute. This is a series of business-to-business seminar series that we put together when TEPHI was created, and my colleague Rocio Rodriguez will describe the group here in a second. And we have a really interesting presentation going on today, which will help us look forward beyond the things that we dealt with during COVID, but more importantly, to equip us for important decision-making as we proceed. So what I want to do first is kick it over to Rocio Rodriguez. She'll describe what TEPHI is and also kind of give some ground rules on how this works. And then I will introduce our speaker for today. So Rocio.
Good afternoon, everyone. Thank you for joining us today. We really appreciate it. We will start off with TEPHI is focused on preparing Texas for the next infectious disease outbreak. In collaboration with communities across the state and leaders in public health science and medicine, we are leading the charge to keep Texas safe and the economy strong. We are housed at the UT Health Houston School of Public Health. TEPHI focuses on collaborating with governmental and professional businesses and academic entities. We also, TEPHI provides additional resources to help prepare Texas communities from webinars to online courses. Please feel free to check out our TEPHI website for that information. Before we begin, I would like to inform the audience that you have the option to use the live transcript button that is located at the bottom of the screen. Once Lee is ready for questions, please use the Q&A. We will make sure to communicate that to him. We also ask that if you could please complete the survey at the end of the TEPHI talk. The TEPHI webinar will be available within a week on our TEPHI YouTube channel. Thank you.
Okay, thank you, Rocio. And also for those that are joining us, the previous TEPHI talks are available on our website, and we've had a variety of business sectors make presentations, so we would encourage you to take advantage and access those from the different settings. So we're very pleased today to have Lee Spangler speak with us, who is now also a member of the UT family here. So we got the secret handshake there. So has extensive expertise in the healthcare sector and has served in several leadership capacities, notably as the head of the Medical Economics Division at the nation's largest state medical association. And that's going to be important with regard to the discussion today. He guided the association's policy efforts in insurance matters. He most recently served as the vice president of Texas governmental relations with Blue Cross Blue Shield, which I imagine is a huge database. So that I'm curious to hear about that one in particular. Most recently, he's become an associate professor at the UT Health School of Public Health in Management and Policy Community Health there, and is housed in Austin. And he's currently contributing to the establishment and development of the Texas All-Payer Claims Database for the Center of Healthcare Data as executive director, which is very germane to what we're going to talk about today. And it's I think, very powerful insight for businesses to begin to understand how that data may be used to make strategic decisions for the protection of employees, but also for the organizations as well. So Lee, thank you so much for taking the time to do this. I know you're a very busy guy, but I'll turn it over to you. And it looks like there we go. We get the screen shared, so I think we're in good shape. So thanks.
Thank you, and it is my pleasure. Again, I am Lee Spangler. I'm an associate professor at UT Health Houston School of Public Health, and I'm executive director of the Texas All Payers Claim Database, as you just heard. I've been in this space for a number of years and worked with physicians for quite a long time. One of the better compliments I ever received from a physician is that I was a fast-talking Texas lawyer, which apparently I am. But for purposes of today, I'm going to try and speak slowly and calmly so we can get through the presentation. And I hope you enjoy it and find it useful. So it is my pleasure to introduce the Center for Healthcare Data to you all, as well as the All Payers Claim Database, which I lead within the center. So I do work at the Center for Healthcare Data. and that the center is dedicated to making healthcare data accessible, accurate, and actionable for Texans of all sorts, but most especially for clinicians, researchers, policymakers, as they make decisions that affect their patients and Texans generally through public policy. We want to make sure they have the best information available at their fingertips so that they can make good decisions. And that's what we're dedicated to. The Center for Healthcare Data is the largest research accessible healthcare data repository in the state. Here on this slide, you see on the right side a number of our data sets. They range from discharge data to medical claims data to medical record data, as well as a data set that we created on our own here at the center dealing with non-medical drivers of health. And it's one of the newer data sets we have that we're particularly proud of. All of these all these repositories are available for persons who are engaging in academic inquiry and public policy research. We aid those who come to us by providing expertise as well as engaging in our own research and work. We have a number of PhDs who are well-versed in data analytics, clinical medicine, public health management. So again, everything at the center is devoted toward improving health in our communities. So today I'd like to focus on, I kind of talked about the broad array of the data sets that we have at the Center for Healthcare Data, but I want to focus on healthcare administrative data and how that can be used for population health. Now, when I talk about administrative data, what I'm really talking about is a collection of the data that is used for billing purposes to insurance and government payers. It is actually the claims that are submitted by physicians, providers, and facilities to substantiate that they've provided a service, why they provided the service, to whom they provided the service, and what they believe is the appropriate payment for that service. So you can kind of tell, kind of the who, what, where, and why in that litany that I just shared. Using claims data can give you a pretty good snapshot of a individual patients or group of patients, if you're really doing statistical analysis, their interaction with the healthcare system. You can tell when they visit the physician communicates what diagnoses they may have arrived at as a result of that visit, or maybe it's just a well visit. But then you gain insight into the interventions that the physician recommended by looking at the prescription drugs that are dispensed later, whether or not there's additional lab work that occurs. You can get insight into whether or not that recommended medical intervention was effective by seeing whether or not there was a subsequent visit to the physician, or even worse, maybe there was an admission to the hospital as a result of not resolving the particular malady that was being examined. So you can get an idea of what's happening, how well people are interacting with the system, and what kind of recommendations are being made, and whether or not they're efficacious. And if they're not efficacious, of course, that means they're costly. If you provide a service that's not appropriate or doesn't do the job, or that another service would have been better, that's costly to everyone. And in fact, through administrative claims data, you can get a good idea even of how benefit design and the availability of insurance coverage helps or hurts a particular interaction with the healthcare system. So that's really what I'm talking about. I'm talking about bills submitted for payment and what that information can tell us in terms of public health. So how do we use at the Center for Healthcare Data this kind of administrative claims information? Well, surprised, why would I mention disease surveillance at this meeting? It's because it's an important aspect of what we do and what TEPHI does, of course. So disease surveillance is one of the more important things we can do with administrative claims data. We can use it to monitor disease prevalence incidents and healthcare outcomes across regions almost in real time. I've got real time on here, but it's almost real time. I mean, you need the submission of a claim for payment in order to really get that information in the system. So there is some delay, but believe me, people don't wait around to get paid. They submit their claims when they can. Our use case, how we engage in this, and I will share a little bit about what we hope to do in the future. I've got one slide on that. But if there's one thing you can do after this particular presentation, I'd like you to Google Health of Texas dashboard after this presentation is done. And if you do that, the first or second link, if you do it on Google, is going to bring you to our Health of Texas dashboard. You'll be presented with a graphical representation of the state of Texas, separated into Medicare, Medicaid, and commercial insurance. And through that dashboard, and it's publicly available right now today, you can get an idea of cost and quality across the state, prevalence of certain medical conditions like diabetes and asthma, all of that, and utilization of certain services. All of that is already being made available to you. And that's a pretty good example of how we can contribute to this kind of surveillance. We also engage in health economic and outcomes research. For example, we evaluated a collaborative service model between a supportive housing provider and a managed care organization in the Medicaid program. So basically just someone who provides insight into secure housing partnered with a managed care organization. And we determined whether or not that particular collaborative model, whether or not that improved cost or quality. And as you might not be surprised, since I'm presenting this as a use case for you all, is that evaluation actually discovered that when you provide people with information about good nutrition, when you make them secure in their housing, that their behavior in the healthcare system changes, and they don't go to the emergency department as they did previously. So that was actually a very good evaluation and showed that partnering with non-medical entities in a healthcare setting can be important. Since we're talking about data sets of billing information and the number of claims that are filed by providers of all types, physicians, facilities, you can get an idea that there's a large data set out there that can lend itself to review. And actually, we do engage in statistical analysis that can aid us in making predictive predictions and just really dig into the data and gain an understanding of what's going on. What our leaders at the center, along with some of our researchers, did was they developed a COVID-19 severity index to give other researchers the ability to really create a disease profile for COVID-19 in a way that just didn't rely on hospital admissions. If you recall, a lot of discussions around COVID-19 about how severe the disease could be always centered around hospital admissions. Well, by using administrative claims data, we could gain an insight into the lesser severe aspects of COVID-19 when someone would show up, say, to an urgent care clinic or to a physician's office, and get an idea of what the true scale of the impact of COVID-19 is. And then we provided that to other resources, researchers, so that they could also utilize our insight into how to create that scale. So we are committed to working with all sorts of various groups. We work with researchers, foundations, healthcare organizations, medical groups, hospitals come to us wanting insights into their particular performance as compared to the rest of the state, things like that. And of course, governmental agencies. We do a lot of work with governmental agencies as well. And I'll be sharing with you some of our experience with state agencies in a few moments. So now let me also kind of highlight what I'm really working on at the Center for Healthcare Data personally, is the new Texas All Payers Claim Database. This is our newest resource at the Center for Healthcare Data. And as you might imagine, something as big as an all-payer claim database needed some legislative encouragement, if you will. So actually a law was passed, House Bill 2090 was passed, about 3 years ago now, to establish the APCD at the Center for Healthcare Data. Again, we're the largest researcher accessible data set repository in the state of Texas. It's a natural place to put the APCD. And the legislature established the All Payers Claim Database for the legislative purposes of improving healthcare across the state, improving the affordability of healthcare, and then offering some sort of transparency in the marketplace as it comes to costs and also utilization and availability of care. So, what exactly is an all payers claim database? Well, it's not a misnomer. It's exactly what it sounds like. It is a collection of the administrative claims data from all payers in a state. There are about 24 other states that already have an all payers claim database up and running. And we're in the middle of the pack, being around 24, 25 in terms of the establishment of an APCD. The APCDs as a policy concept really started in the Northeast, New Hampshire, Massachusetts, Connecticut, but it has been, as a concept, been widely accepted across the country. And so Texas, we have joined the APCD world. So basically, the state commands as many claims as might be shared with the APCD to be shared with the APCD. It is then submitted by all those payers in a standardized format. You want to be able to compare consistently one carrier's set of claims versus another set of claims. So all of them are submitted to us using the same format known as the common data layout. And then, of course, our work is to put all of that together into a data set that is useful for researchers and others. So it's exactly what it sounds like. So in Texas, when I say all payers, what do I really mean by all payers? And it's not exactly all payers. It's all payers that a state can regulate. So maybe to give you some insight into what this data set isn't, let me talk about the gap, if you will, those payers who don't have to submit information to us. For many of those who are here on this call, this webinar, I'm sure you're well aware that there are always issues regarding state regulation of fully self-funded employer ERISA plans. These are those truly self-funded, large employer, multi-state health benefit plans. They enjoy a federal protection from state regulation under the ERISA laws. And as you might expect, if you're knowledgeable in this area, the United States Supreme Court, there was actually a case specifically on whether or not an ERISA plan has to provide information to an APCD. The US Supreme Court said no, ERISA actually preempts state activity in this area, so a state can't require an ERISA plan to provide information. So large employer plans aren't necessarily fully represented in the Texas All Payers Claim Database because of that Supreme Court decision and the federal law around it. That doesn't mean, though, that they can't voluntarily submit. And we do have a few large employer plans who do submit to the All Payers Claim Database. And if you happen to work for one of those large employers, or or even a mid-sized employer that might avail itself of the ERISA, the benefits of the ERISA law, you can still contribute to the APCD if you'd like to. On a voluntary basis, you can just tell your administrator who actually processes the claims for you to go ahead and submit that information to the Texas All Payers Claim Database. And that's how the other ERISA plans have done it. We also don't have Veterans Affairs data in the All Payers Claim Database, as you might imagine. It's a Department of Defense program, and so we don't get that information. But what it does mean is that we have a whole lot of other payers who do give us information. Medical plans, dental plans, behavioral health. We get Medicare Advantage plan information. Believe it or not, the state does license Medicare Advantage plans, and so we get data from Medicare Advantage. Through the Center for Healthcare Data, we also get claims data for Medicare fee-for-service. We've got the 100% Texas data set. And then we also receive all of the state and government employee plans in the state. So the state employee plan, the Employee Retirement System, ERS, we get their claims information. Municipalities, counties, ISDs, we get information from ISDs, and the Teachers Retirement System, we get that information as well. So basically any payer that a state can regulate is commanded to provide that information to us. Now, when I say that they have to submit information to us, what am I talking about? Yeah, it's administrative claims, but it's a little bit more than that. So every month we receive from the payers across Texas a filing that contains enrollment information, so we know who's eligible for coverage or not, provider information, so that we know what the networks look like, and then also the medical claims, dental claims, and pharmacy claims for payment. That's what comes in every month. Now, we were established by the Act about 3 years ago. It takes some time to put something like this together, as you might imagine. You've got to communicate to all the plans. This is what we're going to do. This is the format we want the information to come in and what it should look like. We've got to buy the systems. We've got to do the programming. So just this past August is when we first started to receive information from the payers. We actually did a little bit of work with the insurance industry and the payer industry, and we were able to obtain some historical data as well. So we have been receiving information monthly now on a go-forward basis, but we also have historical data from January 1, 2019 to the present. So we actually wanted a little bit more than that because if we could have gone back a little bit further in the past, we could have been able to trend some information. But even so, with the 2019 data, we will be able to kind of benchmark things for a pre-COVID world, if you will. So we have some insight into that. And then on a monthly basis forward, we're going to get this information from all of these payers. We have 205 registered submitters to us. So the way to think of it is not all of these payers process their own claims. They hire an administrator to do it. And then several payers might hire the same administrator because that's what they're in the business for. So, a company X doesn't actually provide us with their information, even though they're technically the payer for a particular healthcare claim, say. They ordered their administrator to provide us with that information. So we have 205 actual entities that submit on behalf of many, many more payers in the state. The majority of the information we get, though, comes from just a few of the payers. So your Blue Cross Blue Shield, United, Cigna, Aetna, Centene, those are really the entities that submit the majority of the data we receive. But there are plenty of smaller administrators as well. And also, one of the unique aspects of our data set, again, it has Medicare information, it has Medicaid information as well. We receive claims information directly from HHSC for use in the APCD. So you can get a good idea of what's happening in the government program world as well as in the commercial world. We estimate, once we get the data sets cleaned up and ready for researchers, that we'll have information on 18 to 20 million individuals in the state of Texas. Now, some of the things that we hope to do with that information, of course, we have the information, the legislature said we're supposed to have it, but that means we have to give back and make sure that we're serving the interests of Texans. And one of the things that we hope to do in that regard is to use our claims data to kind of supplement what's going on right now, TEPHI, with the wastewater monitoring program. As you're all probably aware, the wastewater monitoring program seeks to find viruses and other maladies that are present in the wastewater, and then provide some notice to the public health world as to what might be going on. The idea with a future collaboration with TEPHI is to utilize the APCD to give a better insight into when those maladies are identified, when do patients actually hit the healthcare system. In other words, right now I think they use hospital admission data, but again, that snapshot of what claims data can show you, we can show when people go to urgent care clinics and physician offices to get treated for whatever might be identified in the wastewater. And it's a statewide data set. So we can also provide insights to areas of the state where maybe wastewater monitoring isn't occurring right now. So I'm working with Dean Borwinkle at the School of Public Health in Houston and others, and we're going to also work with the Department of Insurance to make sure that our submission timeframes from carriers offer the best timely information so that it can be used in this fashion. So knock on wood that something like this comes to fruition. Other examples of some clinical research requests that we're getting in regard to the all payers claim database are a couple of actually three kind of day in the life of a patient kind of projects, if you will. It's a little bit more broad than that, but for instance, we've been requested to think about research on the journey of a multiple sclerosis patient, kind of get an analysis of their trajectory as they interact with the healthcare system across various stages of the progression of their disease, and kind of get an idea of what the lifetime cost for taking care of a MS patient really is. Something very similar in regard to to cancer patients, kind of assessing in terms of an episode of care when trying to perform a curative intervention for cancer, whether or not everyone's entirely efficient on that care team, and whether or not there are maybe unnecessary services provided, maybe multiple imaging, something like that, to kind of give an idea of whether or not the treatment team is truly integrated and truly providing efficient care. We're talking with the Department of State Health Services. Right now they have a sickle cell anemia registry. And the idea is to partner up with them to gain further insight using the claims data in addition to their sickle cell registry, to kind of get an idea of what the trends in diagnosis, treatment, and utilization are for people in Texas who suffer from sickle cell anemia. And then finally, we just started talking to HHSC, and that's again the Medicaid agency for the state of Texas, to use the APCD to identify patients who have hyperemesis gravida and see whether or not there are opportunities to provide earlier interventions and improve outcomes. And for those of you who don't know what hyperemesis gravida is, it is severe morning sickness, which can disrupt nutrition and cause many, many problems. We are called upon by the legislature to issue a report from the APCD every other year. And we do have to make this data available to others as well. So it's not just a function of the center to do this research. Once we get the data in a spot where we like it, we can provide it to what the law calls qualified research entities, which are basically certain nonprofit associations who are dedicated to improving affordability and care, institutions of higher learning who are researching those same issues, and then also healthcare providers themselves. In order to, because this is, of course, a medical claim data set with a large number of individuals in it, we need to make sure it's all protected and used appropriately. And all research that's performed with the Texas APCD, including research at the center, has to be accompanied with an institutional review board letter or review to let us know that the research that's being requested is appropriate and the protections are there to ensure ethical research is being engaged in. And then finally, the law actually requires us to create a portal statewide, but also that allows people to dig down to get an idea of what cost and quality and utilization and what kind of access to healthcare people have in their particular area. Again, there's a need for transparency in the healthcare sector, and that's one of the things the APCD is supposed to answer. So let me kind of change gears again away from the APCD a little bit, and let me talk a little bit about what the center does again in terms of big data. And it's not just big data, it's big healthcare claim data, big administrative data. It's another activity commanded by the legislature, so don't be surprised by that. The General Appropriations Act a number of years ago actually commanded the 5 agencies that you see here on the screen to make their data available to the Center for Healthcare Data to examine the health benefits that are provided in those programs or the public health that's provided by, say, the Department of State Health Services, to see whether or not there are lessons that can be learned across the agencies and whether or not there are benchmarks. Maybe one entity performs better than another, that maybe all of the agencies can kind of rise to meet that particular benchmark. We call it at the center just as the 5 agency project, but there's a much longer name in the state law, and we don't have to. The collaboration among agencies, it was on the other side. Yes, cross-agency collaboration, but we call it 5 agencies project. So these agencies got together and discerned, what are the areas of focus that we have to look at in terms of achieving the goals that were set out by the legislature in the Appropriations Act. And right here, the items laid out as to what they thought was important. And of course, cross-agency quality metrics is one of them, benchmarking. But what I want to focus on for just the next few minutes, and I'm almost done here. I want to talk a little bit about the investigation of low value care across these entities. And first, what is low value care, right? It's services that are deemed unnecessary. Of course, if you provide an unnecessary service, it's really not, it's not worth much. There's not a lot of value in an unnecessary service. But also, if a service is provided that is more costly than alternatives that have equal efficacy, that's also low value, right? You should be providing the lower cost, the most efficient service. So often when you talk about low value care, people talk about it in terms of potentially preventable activities or potentially preventable events. And for the purposes of the discussion here, inpatient admissions when they otherwise shouldn't happen, or emergency room visits when they otherwise shouldn't happen, are certainly preventable events. So they're low value care. If you go to the ER or emergency department when a visit to the clinic is more appropriate, the clinic visit being a lot more affordable is probably the best place to go. So here in the Medicaid program, for example, we reviewed upper respiratory infections and ear infections in Medicaid Star. And all you need to know about Medicaid Star is that that's really the program for children, indigent, and indigent might be a hard phrase, but low income, pregnant women and low income families. And discovered that there were about $58 million worth of low value healthcare being delivered for ear infections and upper respiratory infections because the beneficiaries were going to the emergency department rather than a less urgent setting. And so a little bit of education and a little bit of repeated messaging will improve how people use the emergency department in terms of earaches and upper respiratory infections. Of course, sometimes it's appropriate to go to the emergency department, although, for instance, asthma might be a lower respiratory issue generally. Upper respiratory infections might exacerbate it. Sorry about that. But certainly that would make it an appropriate reason to visit the emergency department. We also reviewed emergency department visits for migraines for the fiscal year of 2019, especially in regard to the teacher retirement system, and discovered that 74% of the visits were potentially avoidable. So when someone had a migraine, rather than going to a clinic or to their own physician, they went to the emergency department instead. And one of the interesting things that was discovered is that 45% of the emergency department visits would generate an order for a CT scan. Now, the medical community has concluded, and best evidence shows that really you don't need a CT scan for migraines. An MRI would be sufficient for the evaluation of the patient. So 45% of the time, when someone went to the emergency department, even though that's the most expensive place to go, they also had a very expensive imaging service provided at the same time, almost half the time. And it was even discovered that 5% of outpatient visits, so even when they went to the right place, that CT scans were ordered rather than reliance on the MRI is best evidence. Best medical evidence would show that you want to pursue an MRI rather than the CT. So it indicates that there's a potential overuse of neuroimaging. And even worse, depending on the particular issues for the patients, but still 38% of the patients who had these interactions were prescribed opioids for the migraine treatment, which is really not appropriate. There are other migraine-specific medications that are really better to be used. So I guess the key takeaways here, and I see that there are a number of questions that have come in, so that's good. I know we have some time to answer those questions, but at the end of the day, claims data is useful. It gives you a good picture of how people interact with the healthcare system, what that system costs people in terms of what is charged and also what is paid. And we at the Center for Healthcare Data, we work with a large number of people, government agencies, researchers, foundations, hospitals, medical groups, and we work with them on a large number of topics and issues that are important to them. And that's the way we want to help out as well. So with that, if you actually want to contact us and you have an idea that you want to work with us on, here's our contact information. And again, I encourage you to do that Health of Texas dashboard Google, and you can see kind of what we do for the state of Texas just is returning. It's publicly available for everyone to look at. So with that, I'll kind of stop the share and not disconnect. I'm going to stop the share.
Oh, you're not allowed to leave yet. Thank you.
And I hope this was helpful. I hope it was a good introduction to what we do at the Center for Healthcare Data, and the new data set that I'm kind of happy to kind of lead up, the Texas All Payers Claim Database.
Right. So first of all, thank you. I've made a bunch of notes here. One of the cool things about running these TEPHI talks is I get the first questions. But I do want to back up a little bit because Lee, we have a spectrum of individuals and backgrounds on these TEPHI talks, and so I think it might be prudent to emphasize the notion of the protection of the data.
Right.
With regard, because I don't know if the average person understands how the data is de-identified, and that may cause some people something askance. So I just thought it might be good to, before we get into the questions, it might be good to underscore that.
Yes. So the data sets that come in, they're not identifiable. Well, let me back up. So the claims information that comes to us is identifiable. It is claims information. It'll have patient names and physician names and hospital names. And then we are charged, and actually the law itself, in terms of the All Payers Claim Database, says that we have to create a data set that is de-identified for use, for the public portal, so that you can't go into our portal and find out, what happened to Lee Spangler last weekend. I heard he had a health incident. So we are very careful about protecting that. That's another reason. That's another reason why, even for researchers, we're asking for the IRB letter, where the IRB, the Institutional Review Board, can say they don't need identifiable information to do this research, and so this is the way it's done. Or if they need some sort of aspect of something that might be tangentially identifiable, that there's an ethical reason why that would occur, and then how this is to be protected in any reports. But any reports that go out, patient names have to be protected. And actually, the law even protects those ERISA plans that voluntarily submit information to us. So if you're a large employer, you might have a footprint in your industry that if someone, even with what is typically de-identified information, your competitors might come in and say, hey, how do I evaluate my competitor's cost versus my cost? Well, voluntary submitters don't have to worry about, being identified in the data set. However, just last session, the legislature modified the act so that providers can be identified in resulting reports from the APCD. So if an entity wants to come in and talk about who are the most efficient hospital systems for malady X, someone could come in and do that research. So that was changed. So providers, that kind of transparency, knowing where to go, knowing who's the best, the legislature's decided is important for the public to know. So that can happen. But in terms of patient protection, no, patient information really can't get out. And also, and I know this is going to get way into the weeds. If a researcher comes in and says, I want to use the information, I want a copy of it. They don't get a copy of the information, even the de-identified information. Everything's going to be done by sandbox and virtual machine so that we know where the data is, we know who's accessing it, and that if something is occurring that shouldn't, we can turn it off.
Yeah, I just wanted to reassure those, we have 130 or so folks on there and from a variety of disciplines to reinforce that. And then I have one other quick one, and I'll turn it over to, we can get to the chat questions here. You mentioned early in the presentation about the notion of non-medical drivers of health. And I was wondering, for the participants in this thing, could you maybe give a few examples of that? Because I'm not sure people outside that don't, aren't involved in public health all the time perhaps would understand what that means.
And I'm sorry, I guess I
No,
did talk code a little bit there. A good example of a non-medical driver of health is access, whether or not there are a sufficient number of primary care physicians in a given area. That is a non-medical driver of healthcare, because if I don't have a physician office close by, but I have a freestanding emergency center close by, I might go there to get my regular care rather than a physician's office. And that means more cost to everyone.
Right.
Typically, I'm not saying that freestanding emergency centers cost a lot, but emergency care costs a lot.
Right.
Another example would be the prevalence of people who smoke in a given area, smoking. We actually have a way to identify whether or not certain areas of the state exceed the mean for smokers versus other areas.
I'm
That's
curious.
important.
Yeah, I'm curious, does that, the data or the analysis you're doing, does that include things such as like a food desert where they're not accessible to healthy foods?
We do have some of that information,
Okay.
and there are a number of other measures that are honestly not coming to mind. I'm sorry about that.
No.
But yeah, it's not just those 3 items, but yeah, there are many such insights.
Yeah. Okay, great. Okay, I'm gonna stop. Either Rocio or Leah is compiling the questions, so I'm gonna turn it over to you guys.
Absolutely. We've got quite a few here in our Q&A box, so we'll try to work through them. And they came at different times during your presentation, Dr. Spangler. So we'll see what we got here. First one, when will the Texas all-payer claims database be accessible to researchers?
We're hoping that it will be accessible the end of this year, early next year. As you might imagine, getting all of this claims information, just getting it is a Herculean task. So now what we need to do is create some indexes so that we eliminate duplication. So we have a patient index and a provider index that we have to create. And then we can actually have a data set that is good enough to provide to researchers. It is hard to take billions of lines of claims and then turn it into discrete, identifiable, patients. So what we're working on right now, for instance, the master patient index. My name's Lee Spangler, and my oldest son is Lee Spangler. And we've got to be able to distinguish between senior and junior, and do it accurately in order for that to provide researchers with a valid data set, right? So what we're doing is we're using an algorithm out of the UK that is used for their census in order to identify individuals. And then we'll create that index and then make it available to researchers. But it's not just as easy as putting it all into, as you might suspect, into a Green Plum or Postgres database. It's harder than that.
So I think this next one you might have kind of addressed, but what is the difference between all payer claims database data and inpatient outpatient data? Is the inpatient outpatient data derived from all payer claims database data?
So no, actually, if inpatient and outpatient data actually comes from the facility itself, usually through surveys or other data collection methods. So it's more clinical in nature. APCD data is truly claims information. It is the claim for payment that is submitted by the provider or facility, and it conforms for those. I'm going to use some technical terms. The federal government has actually issued regulations as to what has to be on a claim form and what an answer from a healthcare payer to a provider has to look like. Those are 835 and 837 transactions. Very standard. That's what the APCD gets. Inpatient, outpatient data is a little bit more clinical because it comes directly from, because it comes from the facility itself.
Okay. Do you know if this will be available to re-reviewed? I'm not sure. Or maybe to be re-reviewed. I'm not sure what they mean by that.
Well, I don't know what they mean either, but I think my slides are going to be available. Maybe that's what it is. And I think you all are going to put this on YouTube.
Yes, absolutely.
Okay. So I think maybe that's what they might be getting at.
Yes. All right, we'll move on to this next one then. Have you or your group been tracking the re-enrollment process of Medicaid after the ending of the public health emergency? Texas is currently gaining national attention due to alleged violations of the ADA and other accessibility items.
It is my understanding that HHSC is really looking at that. I don't know if any of our team are working. I don't recall that our team is working on that, but yes, we know that, and we know that's an issue. And but I don't think we've got a contract with HHSC for that.
Okay.
I think they're embracing it, but I could be wrong. I apologize for that.
Okay. This one, the claims databases that I know of, such as inpatient database at DSHS, lags in publicly posting data by many months because they have to scrub that data. How does your all-payer claims database manage to avoid that lag?
So, yeah, well, so part of the way that we kind of get around that is to make sure that the information comes into the APCD and that common data layout. It's as for the carriers and the other payers, it's as easy as running a script and then they get us that information. So right now there's a 90-day lag between the adjudication of a claim and when we get that information. We are hopeful that the Department of Insurance is going to bring that down to 30 days. And then once that's incorporated into the APCD, then it's incorporated into the APCD. We have an automatic quality check when the information comes in. Does it conform to the common data layout? In other words, there's a field for zip code. Is that we want to make sure there's no more than 5 or 5 and 4 for a zip code. We do a test for that. There are no letters in it. We test for that. So that's how we do that. And we're hopeful that we'll be able to be a lot faster than I kind of know what you're talking about in terms of getting the data in, but it's because it's a different type of data, right? And let me just say, I'm looking at the Q&A thing, and when will you add advanced AI to the analytical mix? Let me just say that is our blue sky idea at the moment, if you will. We need to walk before we run, and I hate to kind of throw it back at you that way. We just started collecting this information in August, so we're not even 1 year in terms of data collection. We do think AI is important. We know it's going to be brought to the healthcare sector, healthcare world, public health world. But I can't really tell you when. It's in the future, and yes, it is on our time frame. But it's in the blue sky part. It's not so much in the everyday kind of thing. So I saw that and I just wanted to jump on that. Sorry about it.
Wonderful. Absolutely. So this one, and actually the one prior to this, I think we can kind of join together. But she said, if I'm not a researcher, but the owner of a small business, can I receive information to prepare my facility for, say, the top 5 claims for my industry? For example, what are the top 5 injuries or claims of hair salon employees? Because then I guess if you're running a business, a hair salon, you could be proactive in trying to address maybe some public health mitigation tactics there to reduce those injuries or claims. So I guess
so.
Go ahead.
So the answer is probably not, and that's because the APCD does not have a great deal of demographic information, such as who is my employer or what industry, as a member of an insurance plan or a government plan, what is my employment? We don't receive that information. There's actually a protection in the law, kind of getting back to Bob's question about protection of individuals. The state legislature has actually prohibited us from asking for demographic information that isn't on a claim form, so that we can't require, say, carriers to inquire about what is your industry, who employs you, what is your income level, things like that. We're unable to collect because of the way the state law is laid out. And as you might imagine, the more of that demographic information you get, the easier it is to create an algorithm that can identify people. And I think that's part of the public policy rationale behind that prohibition. They trust us a lot with this information, but I think they want to focus on transparency of the healthcare system and not necessarily individuals. So I'm sorry, we probably wouldn't be able to get down to that level. Now,
hey, this is Bob. I'm sorry not to interrupt, but
sure,
I think
no
there's
worries.
another way. I think there's another way to get to what this a person is asking about, and there's, if the individual looks up what's called NAICS codes, North American Industrial Classification, and I don't know what the code is for the whatever the personal care sector or whatever it is, one would be able to find the most common injuries that are reported in that sector, but also would be able to find the most common OSHA violations that are issued in that sector as well. So those databases are available, but I guess to just so we're clear, I think what Leah is saying is that if someone goes to the doctor, for whatever the injury or whatever the malady may be, it's not going to show whether it was work related or what sector they worked in or what caused it. It's just going to be more, what did it cost to take care of the person, right? Am I inferring that right, Lee?
You are correct.
Yeah. Okay. Gotcha. Okay.
Great. Well, and this next one kind of goes into, I guess, that other data that you are collecting. Will APCD data be available at the zip code or census tract level? And we'll use ICD-10 codes to identify conditions.
Yeah, yes to both. Yes to both.
And then will or does your non-medical driver of health data have disability considerations? For example, some areas will have a doctor's office, but not one that takes Medicaid or waiver ability.
I am not apprised that it does. It might have information on disability in terms of demographics, kind of like I mentioned. You can determine whether or not an area has a greater number of asthmatics versus another area, and then you can also pull up that some of the non-medical driver information and see whether or not, hey, this is an area where there are a lot of smokers. Diabetes is the same kind of thing, but I think you're asking for something that's a little bit more deep than that, and I don't think that we have an idea of whether or not medical practices make themselves, very handicapped accessible, for example.
Okay, and I think we'll have time for one more question. How can we as the audience work with your organization to help you achieve your goal?
So if you are, say, one of those ERISA plans that are not required to submit data to the APCD, that is a decent proportion of the Texas populace who works for a larger employer that has fully self-funded benefits. Call up your administrator, and they all have customers of one sort or another that have to submit to us. So call up your administrator and say, put me in that bucket, and then you can contribute in that fashion. If you want to actually conduct some research, if you have an academic inquiry or a public policy question that you think is amenable to the kind of work that we're talking about, that email address that I had up at the end of my presentation, contact us that way, and we can talk about how that can might be done. So a good example of some of the the ways people kind of come in to us in that fashion. We received an email from a leader in a hospital system who wanted to see whether or not their particular disease-oriented department, how they performed in comparison to a state benchmark. But there is no state benchmark because no one's ever calculated it or made it. So they want to actually look at the state, find out what is the standard of care, what should we be aiming toward in terms of a benchmark for the state of Texas, and then does our department and our facility meet that, exceed it, or are we falling down below? So those are the kind of things that we do with, say, the healthcare sector. And I'm sure there's a lot of imagination on this call, so I'm sure there might be quite a few questions that maybe we can answer that it's just not coming to me at the moment.
Well, Lee, we're almost out of time here. So first of all, thank you for taking time to join. For those other questions that may come in, what we've done in the past was to forward those questions on to our speakers, and as time permits, maybe you can send a response, because there'll be some latent ones that come in as well. The presentation is recorded and can get access to it. Our next TEPHI talk is coming up June 18th, so we encourage folks to put that on your calendar as we go forward. Please take the time to fill out your evaluation and I want to thank everybody for taking the time to participate. These have been very powerful webinars that we've had, and the turnout's been great. So thank you all so much. Okay.
And thank you for the invitation. I greatly
Okay.
appreciate it.
Great. Thanks.